Really quite essential to begin to understand the various reasons why people might smoke. And I'm sure you can appreciate there's a whole number of reasons. Essentially, it's a biopsychosocial kind of concept. Socially, psychologically, we may choose to, when we're young, emulate role models, people that we look up to and admire. We might feel peer pressure, so to try and gain acceptance in a group. We might want to try and look older, and this is a lot of the reasons why youngsters might be attracted to this. And arguably, if you think about the advertising and the people that were smoking, particularly over the last 50 years, it was very much smoking culture, popular culture. Everyone smoked. It was difficult to escape in that era, which is why many people did smoke. So despite the various adverse effects, the public restrictions that we see in this new era, the increasing financial cost of cigarettes, which I don't know how much a packet of 20 costs these days, but I'm sure it's a lot more than it used to be. Many people continue to smoke, and the main reason would be nicotine addiction. But there are other factors. People find it stimulating, comforting. It's a pleasurable routine or ritual. They like either making a cigarette, rolling one, or just the act of doing what they have to do now, which is go outside to a smoking place and just do that for the number of minutes that they set aside for that. It could be considered to be a bit of a crutch, almost a release from certain situations, a distraction from workload or stress, or in certain environments. It can be an excuse for a work break. It can just simply break up boredom, monotony, or this nicotine addiction is the craving and the habitual kind of withdrawal effect that leads to them, knowing that withdrawal set of symptoms are going to fade to some degree once we put some more nicotine back into the body. So biologically, psychologically, and socially are the reasons. It's important to appreciate that smoking cessation is a process. It certainly links to the trans-theoretical model of behaviour change that we've talked about before. And it's also really important to appreciate that what works for one person won't necessarily work for another. And as much as people have their own reasons for smoking, they'll also have their own reasons for wanting to give up. Now, there are some evidence-based strategies, and we'll point you towards those shortly. But some recommendations coming from the field incorporate having trying to set a predetermined dates for quitting. This is kind of getting into the stages of change. We've moved from not thinking about it to thinking about it and then planning. And so prior to that quitting date, that predetermined date, the smoker might be advised to try and reduce their smoking habit in that period. Try to identify which cigarette of the day seems to be the hardest one to give up. try to think about what they can do to manage on when they're going to be not smoking. What else are they going to be doing? What are they going to replace? What are they going to replace in their mind? And are they going to make sure that there's some level of support in their home and in their friends and family? Or are they going to be continuously exposed to others that haven't necessarily set a date to quit? And also, as the evidence suggests, the best chance that somebody has of quitting when they're an established smoker is using some form of smoking cessation service, which is likely to involve some counselling and also nicotine replacement therapy. So, we might want to tease out of the individual their reasons for thinking about giving up. And, there's a whole bunch of things. Here's some of the classics, for the person to reduce their risk of early death, to improve their sense of taste, to please the people they live with who don't smoke, to improve the pleasantness of their home and working and living environments, take away the smell and the mess. And also just to commit towards the concept of wellness, this continuum of proactivity to be healthy. So there's a number of ways in which people can still take in their nicotine, which might well help gradually wean the person off the nicotine. But there are even side effects for these. So, just using replacement patches might cause some irritations and some unpleasant symptoms. And the same with nicotine lozenges. So you've got to be mindful of those factors, and they might not be suitable for everyone. I think this is a key image, key infographic from Public Health England, what works. So we can see that, as I emphasised earlier, smoking cessation services, when people take advantage of those, which are free, you just need to find them through your local GP or your local pharmacy, they're 3 times more likely to quit than using willpower alone. Using a nicotine replacement approach doubles the person's chances of quitting, and that's a prescribed replacement or anti-smoking kind of smoking cessation medication. And then purely over-the-counter nicotine replacements, 1.5 times more likely the person will succeed. So just, expecting people to have the mindset and ability to do it on their own is the one that shows the least efficacy. But I think it's all about the individual and what they can put their mind to. I guess a strong, resilient person who has got all the abilities to create appropriate situation, environment and conditions to give up may well manage on their own. And we do have other nicotine delivery systems, not just cigarettes. We have cigars, and compared with non-smokers, cigar smokers face 3 times the risk of dying of lung cancer if they don't inhale. And if they do inhale, 11 times the risk. And cigar smokers have a greater risk of death from cancer of the lip, tongue, mouth, throat, esophagus, larynx, pancreas, and bladder. And also, unfortunately, for people that aren't smoking, greater amounts of secondhand smoke is emanated from cigars. Then we've got hookah pipes, water pipes, bubbly pipes used for smoking flavoured tobaccos through water, considered to be a social group activity. Interestingly, the amount of smoke inhaled during a typical hookah session is about 90,000 millilitres compared to maybe 500 millilitres from smoking a cigarette. and also they increase secondhand smoke in the atmosphere. And then you may be aware of these kind of smaller, more traditional kind of little cigarettes. They're called bidis from India and other Southeast Asian countries, and Critex, clove-based tobacco from Indonesia. And these contain more nicotine than a regular cigarette and increase the risk of lung damage, etc. We've also got smokeless tobacco. So I mentioned snuff, but also chewing tobacco. Yes, this can be sniffed, snorted, or just chewed or left in the mouth between the gum and lip. And it's considered to be highly addictive. You're still getting all that amount of nicotine into the body. You might not be having the same smoking effect and harms of that, but we're seeing the other harms, and it's still carcinogenic. And we've seen this in sport, and this was very recently in, I think it was in The Guardian, this one. Yeah. And they've only recently banned this in sport, and this was kind of quite an established subcultural practice in baseball. And I spotted this as well, the same brand as here that they would have been using here, found its way into Jamie Vardy's hand, interestingly. So we get a dependence on nicotine, we get an increased prevalence of cancers in the mouth and other diseases of the mouth, not just cancers. And so again, it's not so great, not to be recommended. And you'll all be aware of the anatomical snuff box, just overlying the scaphoid there. So smoking and nicotine. So we smoke, we take in nicotine, it gradually depletes in the body. During the period of absorption, initially we get a heightened arousal, mood modulation, some potential pleasure, but then we have a developing tolerance to this and eventually physical dependence. And when we don't have the nicotine, we develop symptoms of withdrawal. So then we have craving and a vicious cycle. So nicotine, this is from a really good article by Benovich, 2010, which is going to be available for you to have a look at. Nicotine acts on nicotinic cholinergic receptors, so NACREs, triggering the release of neurotransmitters. So essentially these are, nicotine is a form of chemical stimuli that causes stimulation of the specialized chemoreceptors, these nicotinic cholinergic receptors. And we get some initial possibly desirable effects, as we just mentioned, which might include a heightened body state, similar to a sympathetic response, which causes hormonal and neuronal cascade, which then results in a short-term psychological and physical uplift, essentially, when you smoke. Obviously, it might have some other unpleasant effects, such as making you feel sick. Unfortunately for the smoker, two other less desirable things tend to occur. So we get tolerance to the short-term effects, meaning that the person develops a craving for more nicotine. And if the person doesn't take in more nicotine, withdrawal effects begin to manifest. And the other key point that happens, unfortunately, the one of the two less desirable things is that progressively we get a whole bunch of harmful effects occurring on the body, and particularly with the act of smoking. So in terms of addiction, we've already kind of touched on reasons why people smoke, and we've mentioned the developing tolerance. So it's kind of pharmacological or biological as described, and also environmental, the various cues to smoke as we've mentioned. We also have to have the issue of the rate of nicotine metabolism in the liver, the rate of this, and which can mean that as tolerance develops, withdrawal becomes even more unpleasant. So as we build up our tolerance and we go without, we get a reduced satisfaction with smoking as our receptors are desensitized to nicotine. And I'm sure you can appreciate a range of vicious cycles that tend to occur. So we might start here: smoking cues, stress, peer pressure, etc. Cigarette smoking, nicotine spike, stimulate these receptors, and while we've added nicotine to our blood and neural chemistry, which adds a certain tolerance aspect to those receptors, at the same time we are stimulating the various aspects following on from that stimulation. So we get release of dopamine, neurotransmitters, and this kind of short-term spike in pleasure, stimulation, physical alertness, etc. But if we go without, then we start to get a reduction in our pleasure from the act. Hedonic dysregulation is what we might refer that to as, and that's linked to withdrawal symptoms as well. And when we go without nicotine, the receptors do regain some of their sensitivity, because remember, tolerance increases the more that we smoke. So if we have a break from smoking, then the sensitivity to the nicotine is reactivated, and we can begin a new cycle of developing of addiction again. It's been said, still in this Benovich article, the first cigarette of the day, whatever time, obviously probably for most smokers it's first thing in the morning, but it has a substantial pharmacological effect, primarily around arousal, but at the same time tolerance to nicotine begins to develop, and we've emphasized this increasing tolerance the more that we smoke, and with subsequent smoking there's an accumulation of nicotine in the body resulting in a greater level of tolerance, and then withdrawal symptoms become more pronounced between successive. So it's a very vicious circle. The more you have, the more you need. And also, these euphoric or hedonic kind of effects tend to lessen throughout the day. So, for those that smoke, nicotine will often be described as a way of getting some pleasure, reducing stress and anxiety. It may be as much the association as the actual physiological effect. So many smokers will use it to modulate their arousal and mood. And smokers may also claim improvements in concentration, reaction time, and performance. Additionally, the relief from the withdrawal symptoms is another key reason for having an improved performance and improved mood. And when people are giving up smoking, you are likely to see an emergence of withdrawal symptoms, which are classically heightened irritability, depression, restlessness, anxiety. And the intensity of these mood disturbances are similar to those found in psychiatric populations. And they're likely to experience anhedonia, the feeling that there is little pleasure in life, and that is similar in the withdrawal of nicotine to the withdrawal of other drugs of abuse. So that kind of summarizes some of the key factors in how people feel. Tolerance to nicotine with decreased effect and increasing dose to obtain the same effect. Withdrawal symptoms after not smoking. Smoking more than usual is a sign of addiction that's not being effectively attended to. Persistent desire to smoke despite efforts to decrease. Extensive time spent smoking, thinking about smoking or buying smoking products. Changing your life behaviours to make sure that you can smoke, and continuing to smoke despite awareness of health hazards. So we come back to our Besner article again, which is one of my favourites, particularly useful for this module. And Janet Besner talks about smoking cessation as being one of these areas for therapists to help promote health and wellness. And so that she's encouraging people to think about the 5 A's and 5 R's, which we're going to briefly look at, and some strategies that we as therapists might be able to employ. So it's about bringing up the topic, being a role model, considering the possibility for doing some kind of screening, an assessment, developing our skills in motivational interviewing, perhaps knowing how to signpost or refer to appropriate professional support, and appreciating how physical activity, relaxation strategies, and other ways to improve our whole health can be incorporated into a lifestyle that previously didn't have them. So the 5 A's, I'm just going to briefly touch on this and then point you towards some resources. So the 5 A's is asking about tobacco use, advising, providing advice to quit, assessing, so assessing the client's willingness to quit, assisting the client to quit through referral or counselling, and arranging for follow-ups for ongoing support and guidance. And the 5 R's are for those who are perhaps not yet ready to cease smoking. So, relevance. So exploring ways in which quitting could personally be relevant to that person. Exploring the risks, so asking the client to identify potential negative consequences from smoking. The rewards, asking the client to identify potential benefits of smoking cessation. Roadblocks, asking the client to identify barriers or roadblocks to quitting and ways to overcoming barriers, and repetition. So, each time you see someone in a professional encounter, try to engage with them about this, not in a patronizing or dominating way, but in an open style of motivational interviewing. So this particular document is particularly useful, I think. It links to what Besner was talking about, and I've put this article for you on the website for health and wellness. And I'm not going to talk you through all of this, but I would encourage you to look through the slides and have a read of the document. It gives you strategy, okay? And obviously, let's just link this briefly to your case studies. These are the type of things that you may well choose to build into your case management. So the stages of change, which we should all know now: pre-contemplation, contemplation, preparation or planning, action, delivery, change, and then maintaining it. And hopefully that's where we all end up in terms of having a wellness strategy. But obviously there are barriers and challenges along the way, so we have to build in relapse prevention. And we can expect relapses whenever behavior change is a challenging process. Motivational interviewing then is it was designed for people who were somewhat ambivalent about change. It's about kind of helping to raise their awareness. The spirit is empathic, collaborative, non-judgmental, respectful, and trusting. That's what you have to create as an environment, and the various techniques which we've talked about. And I think you need to, it's so helpful to be able to communicate with clients in this way when you're a health professional. I can't really overestimate it. And these are the two main people, William Miller and Stephen Rolnick. And you can find lots of resources written by them in this field. And also the document that I've pointed you towards also has strategy on motivational interviewing. So have a look at those. I'll also just quickly point you towards the NICE guidelines for stopping smoking. This is fairly recent, 2018, so you've got the link here. I can put the document on the canvas for you as well. But the main kind of recommendations for health workers in both primary and community settings, which is going to cover all bases really in terms of people who work with in health. At every opportunity, it's like the physical activity guidelines. At every opportunity, ask people about it. So, are they smoking? And advise them to stop smoking in a way that's sensitive to their needs. People being referred for surgery are advised to stop smoking before the surgery because of the outcomes of surgery are likely to be a lot more preferable if the person has given up smoking, both in terms of improving the health of the person before they go in for their procedure, but also giving that person the best chance for optimal recovery. Discuss how smoking cessation aids could be used, and advice on e-cigarettes as well. Although a lot of this is being updated, like all health advice, every few months. I'll point you towards ash and forest. Interestingly, they're almost like opposite sides of the coin. The action on smoking and health is a fantastic resource for helping people who are ready to make the decision to quit. a fine resource. This side of the coin is interesting because it's respecting people's freedom of choice, and it's more about respecting the rights of smokers. But I think it's important to appreciate both sides of the coin. Lots of resources available on the NHS online. So the NHS 1U website, I'll link here, so have a look at that. And often there will be all kinds of articles, contact for services, information, help, guidance, strategy, and something there for everyone, I would suggest. Very briefly, I'm just going to show you some stuff that you should probably take your own time to have a look at. So nicotine replacement therapy provides a low level of nicotine without tar, carbon monoxide, or many of the other toxic compounds that are present in smoke. And it's available in a range of media, so skin patches, chewing gum, inhalators, tablets, or sprays. Tend to release nicotine slowly, and the course tends to last for 2 or 3 months. It's available both over the counter and on prescription. Most people are able to use nicotine replacement therapy. Certain recommendations regarding children and pregnancy. It's usually recommended to get medical advice first, especially if we've got comorbidities. And as we highlighted earlier, there are side effects of using these. There are some medications. So this one, Champix, Varenicline, reduces the cravings for nicotine. It's only available on prescription, and 1 or 2 tablets a day. Start a week before you try to quit. So this is just something that could be, considered for somebody who has struggled with giving up in the past and never has really taken it to this level of intervention. But again, like most medications, a series of side effects. Another one, Zyban, which was originally used as an antidepressive medication, but it has shown some benefits in helping people quit. Some kind of central nervous system affectation to address addictive behaviours. It's only available on prescription. Normally, again, a week or so before trying to quit. A course will last about 2 months. Again, set of side effects. Then we've got e-cigarettes, also known as ENDS, electronic nicotine delivery systems. Somewhat controversial, in a number of ways. If you're talking about public health and health promotion, there's a lot of controversy surrounding these devices. In some ways, they're a technology and personal kind of piece of kit that could be quite attractive to lots of people people who've never even smoked before. So it allows an individual to take nicotine in through a vapor. Takes away a lot of the harmful compounds from combusting tobacco. No tar or carbon monoxide. They're not available on prescription, and there's a range of types of equipment. So it's controversial. This is what Ash said. The most effective way to quit smoking with NHS help, but the most popular way to stop smoking in the UK is by using an e-cigarette. However, e-cigarettes are addictive because they contain nicotine, and therefore there is no recommendation for a non-smoker to use one. It certainly became a bit of a plague in itself when these things first became popular, and walking to university every day through the streets of Birmingham, having to go through huge clouds of vapor, it's not particularly pleasant. And I think people just get addicted to this new way of inhaling something. But again, I do think they're very controversial. Lots of considerations in how safe they are. We know that nicotine is highly addictive. It's toxic to developing fetuses. It certainly can harm adolescent brain development. It's a health danger for pregnant women. The aerosols, which are the very fine solid and liquid particles in the gas, can contain various types of substances, because it's not just nicotine that people are taking in. It's a lot of the flavors and chemical agents that are being used to create the effect. And also there's unintended injuries associated with them, like these things blowing up in people's faces and what have you. So we've got over 1 billion adult smokers. More than half of these want to quit. This is from the WHO 2020. And also the document e-cigarettes are harmful to e-health. Much has been written about the potential for electronic nicotine delivery systems. And they're often used along with one or more tobacco products, so patches, lozenges, etc., or medication. And there's insufficient data to understand the full breadth of their impact on health, as devices have not been on the market for that long, especially the long-term effects. But it's clear that we still got these harmful compounds in the aerosols that contain toxic chemicals and carcinogens. And it seems that ends on their own are associated with increase of cardiovascular disease and lung diseases. They're harmful. They should be strictly regulated and kept away from children. This is from the WHO, remember. They emphasise that tobacco products and e-cigarettes pose risks to health, and the safest approach is not to consume either. There's a growing body of evidence in some countries that never smoker adolescents, or never smoked, who use ends at least double their chances of starting to smoke cigarettes later in life. So I just add this one again. So if somebody wants to give up smoking, they're probably most likely at their best potential to give up if they seek some support. And obviously doing it on their own is, depends on their individual capacity and situation. Quite like this. Nearly done, by the way. The 4 Ds to help you get through a craving. So delay, wait as long as you can. Do some deep breathing. This is something I would always recommend. Breathing exercise stimulates the respiratory system, stimulates the vascular system, stimulates your hormonal system, and creates a relaxation effect, which in itself creates a release of endogenous opioids. So you're likely to get a beneficial response if you just undertook this. And then obviously a sip of water, drinking water, and distractions. So, think about other things that you can do to take your mind off that initial urge. So you've got an opportunity now to pause the vodcast and perhaps make a list of the key points that you might take from this session. appreciate if you had a little go at that. Just treat it like a real lecture where I actually get you to do something and not just me telling you stuff. And then let's now see, hopefully you've all paused. This is my little list of key points. So smoking tobacco has been around for thousands of years. We went back to pre-Christopher Columbus. We know that smoking became popular in Britain in the 17th century. Really reached a peak of popularity over the last century. You know, from the First World War, and then the smoking popular culture, and everyone who was anyone was smoking. But we started to, at the same time, develop an evidence base for the harms to health from smoking. We had a key landmark paper in the 1950s from the British Doctors Study. The WHO reminded us that we've got over 1 billion smokers in the world. We got a new era in the history of smoking in the 2000s, or the noughties, with smoking laws. We know that there's thousands of toxic components in tobacco. We know that smoking and nicotine are quite a mix and create an addiction. It's a complex area incorporating the biopsychosocial aspects of that. We looked at the tobacco body, that graphic illustration of the harms of tobacco smoking. We looked at the field of smoking cessation that incorporates support services, behaviour change, counselling, and distraction behaviours, and use of nicotine replacements and potentially prescribed medications. We looked at the safety and use of e-cigarettes, and we looked at some strategies for helping people. So we've got some information resources, the NHS, Cancer Research UK, the Action for Smoking and Health, World Health Organization, National Institute of Health and Care Excellence. We've reviewed briefly motivational interviewing. I would encourage you to look over the information in the attached documents, or the documents that are on this week's set of information on Canvas. And I think it's always important for us in our field to appreciate the effects and benefits of a healthy lifestyle. So we talk about the things that people can do and how to do them so that they feel empowered.